The webinar will begin in 5 minutes. Good afternoon, everyone. I know there's a few people still joining us, but we're going to go ahead and get started. Welcome to the second webinar of our Concussion Overview and Update three-part webinar series, hosted by the Office of Lifelong Learning and the Physician Learning Program at the University of Alberta. My name is Denise Campbell-Scher. I'm the Associate Dean of the Office of Lifelong Learning and co-lead of the Physician Learning Program. Our office is committed to providing reliable updates and resources for clinicians, employers, coaches, athletes, support workers, researchers, and everyone committed to addressing the challenges related to concussion. Next slide, please, Natasha. So we're coming to you today from Treaty 6 here at the University of Alberta in Edmonton, Alberta, Canada. And we know we're coming from across the country. So we'd like to acknowledge that we are on the traditional territories across Canada of the many First Nations, Métis and Inuit, whose footsteps have marked these lands for centuries. So just to go over a few logistics for the webinar, if you have questions related to technical difficulties or L3 programs or services, please use the chat function. If you have a question for the speaker, please use the Q&A feature of the webinar. Please have a look at what else has been asked and upvote questions you'd like to have answered. We can't guarantee that there'll be time for the panelists to be able to respond to all of your questions. A recording of the webinar and a Pearls document with resources will be available next week. It will be sent via email to all of those that registered. And subsequently, that's also available on our Office of Lifelong Learning website. MainPro Plus participants can earn certified CPD credits by completing a linking to learning exercise in the MainPro Plus portal. Royal College and MainPro Plus participants can also earn additional credits by completing a personal development activity using the My Lifelong Learning Plan tool. This tool is available for free as a service from the Office of Lifelong Learning and can be accessed from this QR code or from our website. We have not formally reviewed this particular session with the CFPC or Royal College, but it is additionally eligible for non-certified credits. Okay, so I'm going to now introduce our speaker. We're so pleased today that we have Dr. Shelina Babul joining us from British Columbia. She's going to be sharing with us the clinical features of concussion for both the pediatric and adult populations, as well as the diagnostic process for concussion, including appropriate assessment tools. Dr. Babul is a clinical professor in the Department of Pediatrics at the University of British Columbia. She completed her PhD in exercise physiology at UBC in 2001. She focuses primarily on sport and recreational evidence-based research and knowledge implementation with a particular specialization in concussion and traumatic brain injury, and their prevention, recognition, treatment, and management. Her research focuses on identifying critical gaps in injury prevention, concussion research and strategies to promote uptake of effective interventions, and coordination of local, provincial, and national concussion efforts. Dr. Babul developed the Concussion Awareness Training Tool, or CATT, with e-learning modules for medical professionals, coaches, athletes, and other audiences. She's a member of numerous boards, committees, and associations. Recipient of many awards. These include the 2022 CCCIP Award for Collaborative Excellence, the 7th International Safety Media Awards, 2021 Website Gold Award for the CATT. So thank you so much for joining us, Shelina, for your time, and just welcome to everybody who's joining our webinar in person and asynchronously.
Thanks very much. Thank you for having me. I'm trying to turn on my video and it's saying unable to start, but let me just share my screen.
And we can hear you perfectly.
Okay, great. So I'll share my screen here. Can you see that?
Yes.
Perfect. Okay, so let me just move this here. Okay, great. Thank you very much for having me and for the opportunity to talk to you today about such a what I call a unique, precarious injury that there's no other injury with so much gray area such as concussion. So I want to talk to you a bit about concussion, what the latest evidence around it is, and talk to you about a tool, the Concussion Awareness Training Tool, that's available to you free of charge to educate yourself on the latest guidelines around concussion, because the science around this injury is changing rapidly. Oh, hang on. There we go. But before I start, I want to acknowledge that I'm speaking to you today from the traditional, unceded, and ancestral territories of the Musqueam and Tsleil-Waututh people here in Vancouver, British Columbia. In terms of disclosures, I have nothing to disclose other than the concussion awareness training tool has multiple funders. Its sustainability and maintenance is provided by the Ministry of Health here in British Columbia, but each module has independent funders that supported the development and evaluation of each module. So I just want to acknowledge all the funders that you see there on the slide. So we know that concussions happen every day in all walks of life, not just sport and rec related injuries. It can happen with a trip on the sidewalk. It happens in the workplace. You can hit your head taking out groceries on the trunk of a car, motor vehicle crashes, intimate partner violence cases. So it happens. So in every day, it was typically thought that it was just sport and rec related. But we want people to understand what they may be feeling, how to immediately recognize it and know how to respond and know what you should be doing to ensure that your brain heals as in the normal course of recovery. So concussions have been around for a long time, but it wasn't, in my mind, until about 2009 with the death of Natasha Richardson, who was taking a beginner ski lesson at Mont Tremblant back east. She took a seamlessly minor fall, hit her head, said she had a bit of a headache, skied herself back to her chalet, and died several days later from a subdural hematoma. Now, she was not wearing a helmet, and I do believe that should she have been wearing a helmet, she would probably be alive today. But that's not to say that the helmet would have prevented the concussion. There's no such thing as a concussion-proof helmet, but it would have mitigated the severity of impact by absorbing the energy on impact. So I just want to be clear with that. And then in 2010, arguably the world's best hockey player at the time, scores the 2010 winning goal at the Winter Olympics, was sidelined from a concussion or multiple concussions within a short period of time, within 2 days. And that's what really, between 2009 and 2010, that's when media and medicine took note of this particular injury to say, what is this concussion? What is it about concussions that are making people feel off, something's wrong? And then we heard about it in subsequent years and hear about it on a daily basis. And I really like this most recent publication that came out from Vancouver's, a player on the Vancouver Canucks, Travis Dermott. And I love this quote where he says, oh, whoops, where did it go? You've got to take your confidence and ego out of it and just take care of yourself. Players and participants have to stop being heroes to themselves, to their teammates, to their parents, to their coaches, and understand it's their life in their hands that they're jeopardizing. You've only got one brain, you can't transplant it, and you need to know what to do to get better. I want you to show you this little clip here from 2013.
3-1 the final in overtime. I think they've wrestled another time where Minnick was able to get the best of Lewis. So they've split their matches before. They haven't wrestled this year. Minnick's undefeated, 47-0, a sophomore. Lewis 39-6. He's a junior. Lewis behind. Is he going to be able to get the takedown? He does. Lewis of Harvard scores the first takedown, looking for back points early on in this match. And we're going to stop it. Looks like Minnick's injury. I hope he's okay. He's not moving. Finally, now they get him onto his back. Boy, he still doesn't look with it, really. No, so he's got 1:40 left of blood time. He stands up to his feet.
For 4 minutes later, the team,
it's good to see.
best we can, he tries to do a bit of a balance assessment.
Talking with the, whoa. Yeah, he's having trouble. I don't know. The trainer just did a balance test on him. He started to wobble a little bit. We're good to go, though. He's going to give it a go. Not quite yet, it looks like. Now they'll go out of bounds. 30 seconds to go in the second period. And Minnick still doesn't look right. Scramble there by both guys. So I believe it's going to be a 9-3 match. Anthony Lewis of Harvard. And that's going to do it. Anthony Lewis, an impressive match wrestled by him. He's going to be your state champion. 11-3, the final. Anthony Lewis of Harvard, the junior.
And, you know, this was a decade ago, and that's that was happening. Now we've come a long way since then. However, situations like this are still occurring. People aren't recognizing immediately that a potential concussion or a brain injury has happened. And in Mimick's case, he says when you wake up the next day and don't even remember anything. So this is why we really want to raise the level of awareness and knowledge amongst all audiences so that they know how to recognize and respond accordingly. So hello?
Just Denise here. We just wanted to highlight during the video, when you're speaking, just because of the bandwidth issues, we can't hear what you're saying.
Oh,
so
okay.
if there was additional points you had wanted to raise that we just couldn't capture.
Yeah, thank you for pointing that out. I was simply trying to say that, you know, clearly he wasn't able to go back on, and he wasn't pulled. So in a span of, I think it was 12 or 13 minutes, you could see he wasn't right. So that's why I was saying that we want people to recognize and respond accordingly. So how a concussion is handled in the minutes, hours, and days after injury can significantly influence the extent of damage and recovery from this injury. If you sustain a concussion, you don't recognize it, and you continue to participate in activity, you are now 3 times more likely to sustain a second concussion, potentially more severe in nature and prolonging your recovery. And again, if that isn't recognized and you continue to still play, you are now 9 times more likely to sustain possible brain damage and in some cases, sudden impact syndrome or death, which has happened from a high school rugby player, Rowan Stringer, back east. So it's imperative that it's immediately recognized and responded to. And concussions are everyone's responsibility, not just the individual themselves, but everyone around them, from the parent to the caregivers to the education specialists to the physicians. And we want everybody to know accurately how to recognize, diagnose, treat, and manage concussions. So our brain is our information highway. You have billions of interconnectivities with the brain nerves and fibers in the brain. And it's really our organ that allows us to talk, to walk, to eat, to see. And when there's a potential concussion, there's a disruption in these fibers. So our information in our brain is processed at speeds of 250 miles per hour. When there's a jarring of the brain and disruption of these fibers, I like to akin it to an earthquake, where there's fractures in the roads and cars cannot proceed through unless those fractures are repaired. And that's what happens in the brain. There's shearing and tearing of the neurons and fibers of the brain that need time to heal and repair so that information is processed back to the way it was normally prior to the injury. So it's imperative that there's immediate physical and cognitive rest for 48 hours. And I'll talk about that in a minute. In terms of the prevalence, there's about 55 million globally, and 0.7% or just under 1% of the world's population is living with a medically treated brain injury. That includes mild, moderate, and severe. The global economic burden related to concussion is about $400 billion annually, and that's in both direct and indirect costs. About 31% is into the medical treatment costs, and 69% is into lost productivity costs. In Canada, concussions is among the top 5 reasons for workplace time loss. And there's not only health implications to their individual, but there's social implications and economic costs implications as well. So you can see how large an issue this is and a public health concern this is. In terms of the structure of the brain that's impacted, the exact mechanism of concussion is not fully understood. Why do 2 people respond so differently? You can have an individual who takes a significant impact to the head that is completely fine the next day versus someone who, like, as I said, hits their head on the trunk of a car taking out groceries, that's out months on end. So we have come a long way in the last decade, but we have a long way to go. Concussions are likely due to a rotational acceleration deceleration of the brain that causes a series of metabolic cascades, biochemical influx, and changes in cerebral blood flow. And investigators are really honing in on what exactly is happening. Typically, it was thought to be a functional injury only, but we're seeing now that there's structural changes to the brain that are seen months after being cleared to return to participate in activity, changes in white matter, changes in water composition. So we do have a long way to go to really understand what's happening when it comes to concussions. And it's still uncertain where in the brain concussion actually occurs. You know, the area of impact does result in the symptoms that you see, but, you know, in terms of, you've probably heard of chronic traumatic encephalopathy. Why don't everybody have CT postmortem? Why do some and not others? Is it the number of hits, the repetitive hits to the head, the subconcussive blows? Is it the frequency? Is it the intensity? Is it a certain pinpoint area of the brain? We still have to determine what exactly is happening. In terms of the definition, it's an acute neurophysiological event related to blunt impact or other mechanical energy applied to the head, neck, or body that results in the acceleration, deceleration, rotation of the brain. It's immediate or transient altered brain function. So signs and symptoms can appear immediately or subtly after several days later. And that's a really important point, because when kids are taken off the field, they're asked a few questions, they're totally fine, they respond, and they're put back in the game. And that's not necessarily the right thing to do, because it can appear subtly over several days. And there's an absence of gross structural abnormalities, such as a skull fracture or a bleed to the brain. It's such a precarious injury. It's not just black and white. This is an injury that has a whole lot of gray area. A concussion is a traumatic brain injury where there's a window of vulnerability to the brain that needs time to heal. It's a complex pathophysiologic process that occurs when there is an impact to the head or other part of the body. Loss of consciousness does not need to happen to be diagnosed with a concussion. In fact, it only happens in 10% of cases. Typically, imaging, CT scans, X-rays will appear normal. Unless there's a bleed to the brain or a skull fracture, your typical neuroimaging will appear normal. And there's to date no diagnostic criteria for a concussion. I mentioned that signs and symptoms can appear subtly over several days, and symptoms can last for days, weeks, or months. But there is evidence to show that the number of symptoms that you have will be related to your recovery. So the more symptoms you have, chances are your recovery will be longer. And there's no magic bottle of pills for treating concussions. You get asked that question all the time. What can I give them so that they can play in the Nationals in 2 weeks? The only treatment is immediate, up to 48 hours of physical and cognitive rest, and then following a slow, active integration back to activity as tolerated. And I'll talk about that as well. So really quickly, some misconceptions versus facts. You know, 10 years ago, it was the patient must be woken up every 2 hours in the night. And we don't recommend that. That's not the current guideline. You want them to sleep throughout the night. You can monitor them for normal breathing, no changes in skin color, but you want to let them sleep. You want that brain to heal. Patient must be put in a dark room and avoid all activity. We now know that that's not the right thing to do, because that leads to mental health symptoms. But we want them to rest again for 48 hours. I mentioned the loss of consciousness, only in less than 10% of cases. And it's not just a hit to the head. It's a hit to the head or another part of the body that causes your brain to move around rapidly inside the skull.
Depending on where your brain is injured, physical symptoms of concussion may include headache, nausea, dizziness, poor muscle coordination, light sensitivity, blurred vision, ringing in the ears, slurred speech, and loss of consciousness. You may have mental and emotional symptoms, including disorientation, confusion, memory loss, inability to focus and concentrate, irritability, and
depression. And I really like this video because it really shows you the areas of the brain that's impacted and what areas, what symptoms need to be treated. And you don't have to have all these symptoms to be diagnosed with a concussion. You can just have one or two. So for a thorough physical exam, you rule out the red flags immediately. And then you want to check the vital signs, level of consciousness, the mental status. You screen for signs of trauma or skull fractures. You do a complete neurological examination, cervical spine examination, visual and vestibular system examination. Now, this is also a very tricky piece because for a thorough comprehensive physical exam would probably take about 40-45 minutes. And physicians don't have that much time because they are allowed to bill for smaller chunks of time. Here in BC, we are working with Doctors of BC to have a specific billing code for concussions and making modifications to assessment because you really can't assess or diagnose a concussion within 5-10 minutes. So there is work being done to develop guidelines around this. In BC, we're also developing GPAT guidelines for concussions, which is going to be the most amount of information that you need to do on your assessment in the least amount of time for physicians. We're just in the process of finalizing the draft that will go out for public consultation, and it should be available by the end of the year. The medical assessment must also rule out a differential diagnosis. Because the signs and symptoms mirror other ailments, we want to make sure we're really treating the concussion and not something else that's going on. And a very simple example I can give you is when my daughter was 2 years old, she fell in the parking garage of our condo downtown. And she hit her head and we went upstairs and she immediately started throwing up and crying. And I took her to BC Children's Hospital and they assessed her and the physician said she's got the stomach flu. And given what I do, I'm like, no, she's got a concussion. And we went back and forth discussing it. And in fact, she had the stomach flu. So we really want to be clear and really understand that it is a concussion versus concussion-like symptoms. Other things to take note of are identifying patients with common modifiers to allow for early targeted therapy and supportive care. So you want to look at the number, duration, and severity of symptoms, signs, sequelae, frequency, timing, and recency of concussions, the threshold, the age of the individual, co and premorbidities, medication, behavior, and the sport that they're playing, if that's applicable. So there's a lot of things to consider when trying to make a diagnosis of concussion. I want to quickly mention a study that Dr. Roger Zemek published, which is a clinical and validated risk score for determining persistent post-concussion symptoms amongst children presenting to the ED. And this risk score was significantly better than physician judgment in predicting post-concussion symptoms. So on the right there, you see the 12-point risk score. So each one gets a particular score. If you're female, if you're 13 or older, etc., and you have a total score, and that is a good indicator if this individual will have PPCS in their recovery. I also want to mention general lifestyle recommendations. You know, you want to have a consistent sleep schedule and duration. You want to make sure that the patient understands not oversleeping because we know that doesn't help in their recovery, to maintain social networks as tolerated so that you don't have mental health implications, to limit your screen time initially and use it as tolerated, and as well as the use of over-the-counter medications and consulting with your physician when using different medications. The good news is that 70 to 85% of concussions resolve uneventfully within 2 to 4 weeks. But you do have a pocket of individuals, 15 to 30%, that will experience symptoms that persist beyond this time frame. And you want to ensure that they get the proper interdisciplinary care for treating their symptoms. This is a question I get asked all the time. When should the individual stop playing their sport? And there's so many factors that need to be considered, and it should be on an individual basis. You know, were there neurological deficits? What was the number, pattern, and severity of previous concussions? What was the duration to recovery? Were there cognitive deficits? Were there abnormalities in CT or MRI findings if imaging was taken? So you want to have all these considerations. And I also want to give another example of my daughter who has had 6 concussions. And I was asked all the time, how are you letting her play? She played competitive ice hockey. And the first 4 concussions she had, there was no red flags. She recovered uneventfully within, a week. I had no reason to have her stop playing her sport. The 5th concussion was when I first had my red flag, where her recovery took a lot longer. And it was the 6th concussion that did it for me, that evoked a family conversation and discussion to say, I think it's time to stop playing, because it was the 6th concussion where in the first 24 hours, my daughter is very mathematically inclined. However, in the first 24 hours, she couldn't do simple multiplication. If I said to her, what's 5 times 5? She had to think about it for a second. So that was my second red flag to say, you know what, this is your quality of life. You now need to make a decision. We base all these recommendations on several gold standard documents. One is the International Consensus Conference on Concussion in Sport, a meeting that takes place every year. And the most recent one just took place in Amsterdam in October of last year. And the findings from this meeting will be published at the end of June, as well as clinical practice guidelines for the pediatric and adult population. So we really look to these documents as gold standards for diagnosing and treating concussions. So really quickly, to show you changes that happened in the meeting in 2016, it was identified that prolonged rest until symptom-free is no longer recommended. Return to full-time school should precede return to sport, because prior to that, the focus was on sport. And we recognize that that is not the priority. It should be school, and it should be daily activity, daily life. And then baseline testing is only to be used as an aid in making a diagnosis. Prior to that, there was a lot of emphasis on baseline testing, but now we know that it should only be used as an aid in making a diagnosis. Because if you did a baseline testing on an individual who is writing final exams, they're very stressed. They may be dehydrated, not eating well, not sleeping well. Their baseline test will be a lot poorer than if they're done, say, during the summer months when they're rested, no stress from school. So we now know that it's only to be used as an aid. At the last meeting, some of the important findings that will be coming out shortly is there'll be a revision to the definition of concussion to align with other definitions out there and other position statements. They are developing a sport concussion office assessment tool, which doesn't necessarily have to be restricted to sport, but it can be an office assessment tool. And some of the things that will be included that we think, and I put question marks because we don't know, it hasn't been published yet, is it will look at doing a symptom scale, cognitive assessment, bit of balance testing, cervical spine assessment, neurological exam, and both lying and standing blood pressure. We also know that rest from this meeting, strict rest, is really ineffective and likely harmful. So we want to really stress that. And it will now include parasport, because that's something that hasn't been explored and really needs to be developed. So in terms of quality of care, concussion clinics have popped up all over the place, charging exorbitant amounts of money. So we want individuals to be aware of quick fixes, expensive treatment, and to, concussion clinics that offer single care versus interdisciplinary care. So we want to look for clinics that have interdisciplinary care, that they're licensed medical professions, that they really rely on evidence-based care. So you want to know what tools they're using, what tests, what recommendations are being used. I had one person here in BC say to me, it's cheaper for me to fly to the Winnipeg Pan Am Concussion Clinic to get care versus paying what I am being charged at this one particular concussion clinic. And in BC, we don't have a publicly funded concussion clinic. We have GF Strong, but they also deal with moderate and severe. So it's really hard to get in at times. So I just wanted to highlight this. So this injury is really a conundrum of uncertainty. No two concussions are alike, and it needs to be treated on an individual case-by-case basis. Education is imperative to know how to immediately recognize and respond. We've got wonderful evidence-based research that's happening in this area, but at the end of the day, we know from bench to bedside takes, up to 17 years. But we want Canadians, British Columbians, Albertans, we want everybody to know how to immediately recognize it, know what they may be feeling, and know what to do. In terms of physicians' knowledge, we want them to do a comprehensive assessment, and we recognize that it's time versus money on the billing. So there are things that are happening to try to work around this. We want to make sure there's no misattributions when it comes to diagnosing concussions. And we want physicians to be aware about the individual scamming the system. You hear about workers who say, oh, I have a concussion, I can't go to work, can you write me a note, I hit my head? Or you've got students saying, oh, I kind of smacked my head, I feel kind of off and dizzy, so I don't think I should be writing the final exams. And there've been many situations where this has occurred, so we also need to be aware of that. We also need to standardize our coding. What one physician codes as a concussion, another codes as a minor head injury, another codes as a brain injury. So we're really working to standardize surveillance of concussions. And we want to just be aware of the monetary capitalizations of clinics and manufacturers. We had one manufacturer touting their helmet as a concussion-proof helmet. The child got a concussion and the parents sued this particular manufacturer because they touted it as a concussion-proof helmet. So just really quickly, I want to talk to you about the concussion awareness training tool. Over a decade ago, I started getting more and more calls in my office from parents saying, where do I go? Who do I see? The doctor is saying this, the teacher doesn't believe me. I don't know what to look for on the internet. So we recognized that there was a disconnect out there. So we then did an environmental scan to say, does anything exist out there to educate individuals on concussions? And there wasn't. There was a couple of tools and there was a cost associated with it. So our government said, if we want British Columbians to learn about concussions, we're not going to charge them. The second thing they said to us, if we're going to build something, it shouldn't be just applicable to BC. It should be applicable everywhere, both nationally and internationally, because how we treat concussions here should be no different than how they do it anywhere else. And then we conducted focus groups with all these audiences to say, if we build something, what do you want? So physicians said to us, we want the most amount of information in the least amount of time. Parents said, we want a one-stop shop of resources. School professionals said, we want to know how to support our students, etc. So that's what we did, and we built the concussion awareness training tool. Here is a screenshot of the homepage of the training tool. And as you can see, we have 8 modules down there. We have a recent news section that gives the most latest information on new news pieces that come out, and we've got a social media feed as well. Our most recent 2 modules are the high performance athlete, the university athletes module, that is now mandated in 26 universities across the country, which we're very proud of. And I'll briefly go over that in a minute. The concussion awareness training tool is an educational tool with relevant resources for each particular module. It's built on the learner-centered model of learning. Some like to read, some like to watch, some like to listen. We've incorporated all those pieces. All modules are evidence-based, and we did not reinvent the wheel where there was evidence-based resources that currently existed. So we incorporated all that feedback. The site is reviewed and updated monthly. As I said, the science around concussion is changing rapidly, and we want to make sure all that information is added to the site, as well as ensuring that links are fixed, broken links. I know if I go to a website and I get a spinning circle, chances are I won't go back to that website. So we really want to make sure everything is working. All sites have been evaluated. It's available 24/7 and it's free of charge. So this is just, I'll take you through some screenshots and then open it up for questions. Depending on what module you click on, you'll see it takes you to a page that's relevant to you, as well as with relevant resources and tools and quick access resources that can be used. The medical professional one, you can claim CME credits for it, main pro credits. All courses have a certificate upon completion, but the medical professional one lets you effectively conduct an initial medical assessment for concussion, optimally manage concussion care, and identify when referral to specialty care is necessary. The module for medical professional goes through definition and epidemiology, assessment, management, how to deal with prolonged concussion, and we recently added the role of physiotherapy and occupational therapy to the module. This is the resource section where once you select your parameters on the right-hand side, it automatically populates to the resources you're looking for. So you're not sifting through, pages after pages. We have a concussion recognition pathway that was developed that resides in many of the school boards in our province because they had asked us, can we keep something in the gym or in the office to know what to do if a concussion occurs? We also have stepwise return to activity cards. As we know that recovering from a concussion, you need to follow a 6-stage return protocol or a 5-stage, depending on which one you're doing. And each one walks you through what you should and shouldn't be doing and what you need to do to progress to the next stage or when to regress to the prior stage. So those are available as well as packages. So we really take note of feedback we receive, and the feedback we were getting was, can we have packages that we can keep in our office on our desk when we aren't able to go on a computer? So each one has all the relevant resources you need for that particular audience. And then we have the CATT cards, which is the bottom right, that resides in emergency departments in our province as well. So in terms of knowledge translation, we stopped updating this slide and we put plus signs through each one. So in terms of the learning modules, I think we're now at about 175,000 completions from across the country, mandated in over 100 organizations and schools. So we're very happy at the reach we have received. I just want to show you globally what we've done. We haven't just tailored it to Canada, but we've had reach across the world, and we've been doing workshops in East Africa, in the medical schools in Japan, most recently in Lebanon, and I will be going to South Africa later this year to do workshops on concussion education and the CATT completions. And you can see the evaluation publications as well that have been noted there. In BC, we've also got social marketing campaigns, and you can see the billboards that reside on the major bridges across the province. And in terms of next steps, we are going to be incorporating the new consensus publications into the site. We're going to be updating the site, including more security measures, keeping up with the times on technology. I mentioned the GPAT guidelines. We're going to be doing work in rural and remote communities, incorporating resources on parasports, and doing work with Indigenous peoples as well. So in conclusion, what's needed is astute detection, accurate diagnosis, optimal management, and appropriate follow-up. And I really would like to recognize my team, because without them, none of this would be possible. So I really want to acknowledge them as well. So thank you very much for the opportunity to speak to you today, and I'll open it up for questions.
Wow, that was awesome. Thank you so much, Shelina. So we do have a couple questions in the chat.
Sure.
Try to get your video on again. We can't see you yet. So let's see now that we're.
Let's see, can I do that? Hang on.
Yeah, so we have a few people kicking us off, and just to remind those of you who may have joined later, if you want to just pop your questions in the Q&A section. So Bruna actually kicked us off, Shelina, with a question about whether or not there's any consideration for uptake of biomarkers in traumatic brain injury. Did you want to comment on that?
Sure. Yeah, there is a lot of work being done looking at biomarkers. A colleague of mine, Dr. Cheryl Wellington, is spearheading a lot of the work here at UBC. They are finding certain biomarkers in the detection. I think it's more moderate to severe brain injury, but there is work being done to look at biomarkers in the detection of just mild traumatic brain injury or concussions. So one day, I have no doubt we'll be able to have a diagnostic test where they'll do a blood test and you'll be able to say whether you have a concussion or not. But yes, there is a lot of work being done looking at biomarkers for the diagnosis.
Awesome. Okay. And then the next one sort of relates to some of the wonders I had as well around when you're working on the sidelines or attending a sporting event for some kids or whatever. You were commenting about how the symptoms could develop over several days. And so just the question was, how does sideline assessments help us in determining if an athlete can immediately get back on the field?
So a lot of times you can use the SCATT, the Sport Concussion Assessment Tool, which looks at symptoms, balance, cognitive. But, my feeling is if there is an impact where you suspect there's been rapid movement of the brain inside the skull, or there's been a significant impact where there's been acceleration, deceleration of the head, chances are that individual may have a concussion. And I say this because, again, people can have a significant hit and be completely fine. So we recommend erring on the side of caution. And we say, would you rather be out for 2 days to see if symptoms appear subtly, or for 2 weeks or 2 months or 2 years? So it's better to err on the side of caution and keep them off playing just on the perchance that the symptoms can develop.
Mhm. Okay. And then Roshan was asking just if you could clarify a little bit around the question about rest. So when you were talking about strict rest for the first 48 hours, just exactly what that entails.
So basically what we're suggesting, because there's the shearing and tearing of the axons and glial cells of the brain, we want individuals to rest physically and cognitively for 48 hours. So keep any kind of brain activity to a minimum, because you want that brain to really rest during that time and not have to be taxed with overloading of information. After the 48 hours, we want individuals to slowly and actively integrate back to activity. So day 3, do a very little bit and then watch yourself. Do new symptoms appear? Are your symptoms worsening if you have symptoms? And if they are, wait 24 hours and try it again the next day. And when you can get over that hump, then you gradually increase your activity day after day. But again, waiting 24 hours to see if new symptoms appear or if your symptoms worsen. And if they don't, then you gradually progress to the next stage. And those were the 4 cards that I showed you on the one slide. All these resources are available for download on the site, and you're more than welcome to use it. Or if you contact us, we can mail you the resources as well. But again, it's immediate physical and cognitive rest, followed by slow active integration back to activity. A lot of times people think, oh, I need to stop doing what I'm doing until I'm symptom free. And that's not the case. You may be experiencing symptoms, but you want to keep it so that it's below the symptom threshold. And then you can progress gradually through.
Mm-hmm. Okay, so Abid is asking, at this time with the increased awareness of concussion, do you feel that concussions may be overdiagnosed and treated?
Yeah, this leads me back to my gray area. A lot of time it's so hard because sometimes, and I've heard situations like this where a person will go into a physician's office and say, I smacked my head, but because the physician doesn't have enough time to accurately diagnose it, they'll say, yeah, it sounds like you have a concussion. And so, our numbers have gone up. It's not so much that concussions have gone up, it's more awareness around concussions, but it's really hard to differentiate now because it's being overused sometimes and taken advantage of sometimes. So again, gray area. So we really want an assessment of a diagnosis to be clear and accurate.
Mm-hmm. Okay, and so one of the participants has a great question here, expressing concern about some of these money-making clinics that might be scamming patients.
Mm-hmm.
I was wondering if there's any sort of a process, and wondering about international certification or some sort of controls on such clinics.
Not yet, and that's why I put that one slide to make sure they're accredited, make sure the individuals there are licensed medical professions, make sure it's not just one person, but there is a team there to help look at what tests they're using, what tools they're using, make sure those tools are evidence-based. You shouldn't be charging $5,000 for an assessment and treatment of concussion. That's not necessary by any means. The same thing applies for baseline testing. You had companies charging $7,500, $150 to conduct a baseline test on individuals at sporting venues. That's not necessary either. That's, really overcharging. So you just want to be aware of all these things that are happening because everybody's trying to capitalize on concussions. And, unfortunately, people who are going through it just want to be heard. They want to know that they're doing the right thing or what they could be doing, and people are taking advantage of that, unfortunately.
Mhm. So Jean-Pierre has a great question here. He asks, given prognostication is still limited, and he notes, apologies, he hasn't had a chance to have a look at the CATT online as yet. What's the significance and approach of youth who are not tolerating cognitive loads a year and a half or 2 years later? Is there any sort of a rehabilitation program or approach to help those kids?
So I think that needs to be dealt with interdisciplinary care. So depending on, the symptoms that aren't resolving, and I suspect 2 years down the road, mental health plays a huge role. They should be seeing, specialists in those particular areas to help them in their rehabilitation process, for sure. We don't want to leave it too long because unfortunately we've had significant mental health issues in some individuals and others who have been told there's nothing else I can do for you and have committed suicide. So we want to stay on top of it and ensure that they are cared for and followed through their trajectory of recovery.
Okay, so just folks, go ahead and keep putting some questions in, but I'm just going to interject one of my own since there's a gap. I was really excited to see, Shelina, that you had highlighted you're going to do some work more with rural folks, just because I'm mindful of access to some of these things you're talking about. Could you share with us a little bit about some of the thinking you've got in that space and things you might have done so far?
So we're trying to, in my slide, I said we're trying to engage with iSpark, an organization here, Sport and Physical Activity in the Indigenous group here. We just started it, but we do know that we want them involved in the process of what we can do to develop resources that will help them. If you say, if you ask them about their symptoms of headache, say, for instance, that means something very different to Indigenous people versus what we deem headaches to mean. So we are collaborating with our colleagues in Winnipeg, Dr. Mike Ellis and Dr. Kelly Russell, who have done work with Indigenous people in Manitoba. So we're hoping to learn from them as we work to develop resources or potentially develop a CATT module. We're not sure which would be better, whether it would just be resources or a module for Indigenous people.
Cool. So Hussein has a follow-on question about the biomarkers and was wondering if you've done any work on haptoglobin as a marker for concussion.
I have not. I don't do work in biomarkers. That's my colleague, Dr. Cheryl Wellington at UBC. So I'm sorry, I can't answer that question.
Okay, thanks so much. Shelina, I was just curious, you had also highlighted that some of the upcoming work you want to do is around parasport. And could you just give us a little bit of an overview of that and sort of what the considerations might be that might be similar, might be different?
Sure, yeah. So I just am now on the parasport working group. So just like there's a concussion in sport group, there's now a concussion in parasport group, which I now belong to. So we are trying to develop a module for parasport. So, when you look at, for example, the return to activity guidelines, when you recommend, say, go for a walk up and down the block or go for a jog up and down the block. Someone who's in a wheelchair can't do that. So you have to make accommodations on what we recommend for their return to activity guidelines, or someone, who has cognitive deficits, trying to do an assessment on them is very different than doing it on another individual. So we want to really consider all the different factors that come into play for the parasport population and ensure that we have resources tailored to them that is meaningful, understanding, and really aligns with parasport athletes.
Mhm. And you were mentioning, Shelina, that you do work as well with workers who support people who've been involved with intimate partner violence or perhaps victims of other violence. Can you share a little bit about how this work has sort of supported or moved into that? And for people who are in primary care on the call, things that they might be wanting to be aware of, and when those things are perhaps presenting to them in the emergency department or in their practice?
Sure, yeah. So we developed the women's support worker module for intimate partner violence. Concussions are an invisible injury. So some of the work we did was, one, to develop this module so that individuals know how to support people who come in for assessment, because you can't visibly see the injuries, know what to look for, what to ask for. We've also just finished a project where we've developed virtual reality goggles for RCMP officers, because when they go into the homes of domestic violence cases, they typically overlook the symptom of concussion. They look for visible bruises, broken bones, those kinds of things. So we're doing training with RCMP officers using virtual reality goggles. My colleague, Dr. Mike Ellis, has also developed a really good resource for medical professionals because, he said during COVID, the number of patients that he saw in office who came in with domestic violence just shot through the roof. And he's like, I've never dealt with that. And I didn't know how to address it. I didn't know how to deal with it. So he's developed a fabulous resource that is also on the resource section of the concussion awareness training tool that informs medical professionals on what to look for, what to ask for when assessing an individual who comes in from a domestic violence case. So a lot of work is being done in this area.
Wow, fantastic. Okay, guys, if there's any more questions, Abid put one in there. Awesome. So thanks, Abid. So he says, could you speak again to the structural issues you're seeing in concussion? So I'm assuming that Abid, you mean like from the neuroanatomy perspective, right?
Yeah, it's interesting because my colleague, Dr. Naz Virji Babul, no relation, she's doing work at UBC looking at structural changes that persist well after the individual is cleared to play. So she's seeing changes in neural pathways after the concussion versus someone who hasn't had a concussion. She's seeing changes in white matter composition months and months after clearing. Being cleared to play and after the concussion is resolved. It's a new and emerging area for sure, but it's something that we didn't look at before. We thought it was a functional change that happened to the brain that resolves over time, not a structural issue. But now we're seeing these structural changes that are persisting months and months down the road. So, as I said, we've come a long way in the last decade, but we certainly have a long way to go to really understand this unique organ called the brain, because there's so much uncertainty around it.
Fascinating. That's a great question, Abid. Thanks so much.
Mm-hmm.
Actually, just a follow on from me with that is, are we seeing any difference by age? Like, do we see a difference in kids versus adolescents versus adults?
In terms of structure?
Yeah, and in terms of prognostic recovery and things like that.
I don't think in terms of structural changes in adults, I don't think the work has really developed. I think they're looking at more in the youth population. Hello?
Oh, yeah, we're here.
Oh, sorry. In the youth population, I know they're seeing changes between males and females. And I know youth take longer to recover 2 to 4 weeks versus 7 to 10 days in the adult population. But it's because their brains are developing. They're still young, they're growing, their brains are developing, the body structure is different. So the impact is very different versus an adult who takes an impact, and the acceleration, deceleration of the brain inside the skull. So a lot of exciting work is coming up in all these areas. So I fully expect that the next 10 years we'll have new and exciting research in all these areas.